the endocrine system, and this is for advanced pathophysiology. The endocrine system is composed of glands, and they are very heavily involved in maintaining body homeostasis. These glands synthesize and release special chemicals, which we call hormones. These hormones then travel through the system via the blood to the target organ and then elicit a response at that target organ. We use feedback signaling to control or inhibit release. You must understand negative feedback mainly for the endocrine system, and we also talk about positive feedback, and that usually is with the reproductive system. So you will see both of them. When we talk about negative feedback, this would be a negative feedback loop here. So in the endocrine system, we have the hypothalamus, we have the anterior pituitary, the target endocrine gland, and then the target tissue. That's the main pathway of most of what we're going to be talking about. So you will have one hormone released from the hypothalamus. This is usually a releasing hormone. Then you go down to the anterior pituitary, and then you will have a stimulating hormone. The stimulating hormone goes to the target endocrine gland, and then the target endocrine gland is stimulated and it produces another type of hormone. And then that hormone travels through the blood system to the target tissue and elicits a response within the cellular tissue based on receptors. We have a feedback loop, and let's just take the thyroid for an example. Thyroid here would be your target tissues, which are all over the body, such as your skeletal muscle, heart. So then the thyroid, so we would have T releasing hormone, thyrotropin releasing hormone. So that's going to go to the anterior pituitary. The anterior pituitary is going to release thyroid stimulating hormone. Thyroid stimulating hormone is going to go through the blood down to the thyroid gland. And then the thyroid gland is going to release T3 and T4. And then that is going to travel through the blood to the target tissue of the heart, cholesterol synthesis, muscle, bones. That is the basic pathway. So when the target tissue, the circulating levels of T3 and T4 are appropriate, it goes up and turns off anterior pituitary and turns off hypothalamus, saying we do not need any more hormones to stimulate the thyroid. So it's going to turn them off. So negative feedback basically means I have enough hormone. I do not need any further stimulus, and it's going to turn off the stimulus. Positive means that we're going to stimulate release. So if this was a positive feedback loop, if these were circulating and this came up and was positive, then it would actually still proliferate all of these steps and turn them all on. There are 5 main general functions of the endocrine system, and that is differentiation of the reproductive and central nervous systems in the fetus. We have stimulation of sequential growth and development during childhood and adolescence. And then we have coordination of male and female reproductive systems, which make our reproduction possible. And we have maintenance of optimal internal environments throughout the lifespan. And we initiate and correct an adaptive when emergency demands arise. Endocrine, nervous, and immune systems, they are very intertwined. Regulation of the endocrine system, so there is synthesis, the hormones are released into the circulation, and then these trigger an intracellular response at those target organs. These hormones are released with specific rates and rhythm. So circadian or diurnal, pulsatile or cyclic, and then patterns that would depend on levels of circulating substances such as calcium, sodium, potassium, or other hormones themselves. We also have chronic or acute, and that would also maybe fall into whether it's a circadian or a cyclic pattern versus an acute, which would be a response to, let's say, epinephrine related to a stressful situation. So those would be ways that we would do that. So the thyroid would be an example of a chronic release. Acute would be stress response, and that would be epi. When we're talking about circadian and diurnal, they don't mean the same thing, but they can kind of be classified under that same pattern. And remember that biologic rhythms are any cyclic change in the level of body chemical or function. We do have internal and external regulations of those biologic rhythms, and that does matter based on the body temperature cycle, which would be an internal or endogenous, versus an external, which would be external stimuli such as light, sleep, wakefulness, day, night. And those stimuli are called zeitgebers. meaning time givers in German. And that is those environmental time cues that actually reset the biologic clock to the 24-hour day. So when we talk about circadian rhythms, it means that the endogenously generated rhythm is close to a 24-hour period. Diurnal rhythms are a circadian rhythm that is actually synchronized to the day night cycle. So the circadian rhythm is derived from the Latin phrase meaning about a day, and this is a physiologic and behavior rhythm, and it includes sleep wakefulness, body temperature, patterns of hormone secretion, which is what we're talking about, and blood pressure, digestive secretions, reaction times, level of alertness. So I just included a nice couple schematics here to put that circadian rhythm, that diurnal rhythm into forefront understanding a little bit more as to what is involved with that. When the circadian rhythm is synchronized to the day night cycle, so this would not include anybody who is on second shift, night shift situations. This is someone who has that normal 9 to 5 situation. They're home, they go to bed at normal time when the lights go away and get up when the light comes up. So that would be then classified as diurnal. So in humans and other mammals, it is located in the suprachiasmatic nuclei, hypothalamus. The other gland that is heavily involved in regulating sleep is the pineal gland. This is where our body produces melatonin, and melatonin is heavily involved in the sleep wake cycle. You can see here 9 p.m. to 7:30 a.m. That is when it's secreted. There are more controls of melatonin based on seasonal rhythms in reproduction and then metabolism and appetite as well. Melatonin secretion lasts longer during the longer winter months and heavily involved in making sure we have coordinated rhythms. You can see endocrine, metabolic, and behavior. Disruption of the clock or its synchronization occurs during jet lag, shift work, old age, and it does affect our well-being in mental and physical performance. Over here, you can see some of our hormones and when they're released. Body temperature is high yield when we're talking about sleep cycle. So you can see here, the highest body temperature is around 7 p.m. Lowest body temperature is around 4:30 a.m. Drowsiness increases as the body core temperature falls. When we're talking about pulsatile or cyclic patterns, this would be things such as FSH, LH. They follow a certain pattern or a cycle. Sometimes we will have more pulsatile mechanisms, such as earlier on when we talk about fetal development, we're going to have more pulsatile gonadotropin releasing hormone versus when it gets older, we have more of a cyclic pattern. Then we have patterns that depend on levels of circulating substances. So, calcium, parathyroid hormone, that would be stimulation for the parathyroid hormone to be stimulated, to be released from the parathyroid glands, and then it would stimulate calcium release from the bones and an increased absorption from the GI. Other things to be aware of, that it is regulated by chemical factors, and that would include your blood glucose, and then insulin is released. Endocrine factors would be one gland stimulating another gland, such as ACTH stimulates cortisol, and insulin released from the beta cells in the pancreas would be another example there. And then we have neuronal control, which would be autonomic nervous system, directly stimulates insulin release from the beta cells. So now we're going to take a closer look at hormones. I just thought this was cute. Hormones everywhere. They are everywhere. Okay, so we have those specific rates and releases of secretion, which we talked about. They operate within those feedback systems. They affect only cells with appropriate receptors. So these guys can be floating through the blood system. They are not going to work on anything that does not have that specific receptor on the cell surface. And then the hormone or ligand, it only affects certain functions or activates the target cell. So there's only certain things that it will stimulate. And then only free hormones can activate changes at the target. A lot of hormones are protein bound, but only free hormones can activate. When we talk about free hormones, let's take the thyroid. It's the easiest one to take an example. We actually measure free T3 and free T4 to see exactly how much is circulating in the system, and then that tells us where our thyroid gland is at. We classify hormones by structure, gland of origin, effects, and chemical composition. There are three types of messenger systems that are used within this. We have autocrine, which is the cell targets itself. Paracrine is neighboring cells and regional. And then we have the endocrine, which is circulating hormones. and they have to be into the blood system and transported throughout the body via the blood system and then end up with a target cell. What are ways that we can get hormonal or alterations? That feedback system may fail. We may have inappropriate signals or triggers, and that may elicit responses from whether it's going to be the hypothalamus or the pituitary gland or the target gland. There may be decreased synthesis or excessive hormone amounts. Once they're in the circulation, there may be something going on with metabolism of those. They may be used too fast, too slow, or degraded. They may be inactivated by antibodies. And then also, there may be non endocrine tissues that are secreting hormones as well. So let's look at the three structural characteristics. We have steroid derived, and that is going to be from cholesterol. We have protein derived. We have two type of protein derived. We have peptide, which are going to be those long chains, and then we have the tyrosine derived amino acid, which are going to just be the amino acid ones. The steroid derived are fat soluble molecules made from cholesterol. They are able to pass directly into the cell's nucleus. They do not need a receptor on the outside of the cell. And I have a picture coming up. They will bind to a specific receptor and trigger the cell to make proteins. It has a direct action on the cell. These are protein bound. If they are protein bound, they are insoluble to H2O and they will remain in the circulation longer. If they're a water soluble hormone like the amino acid derivatives and peptides, they can travel freely in the blood because they're more like water. They are either excreted directly by the kidneys or they're going to be metabolized and conjugated by the liver, and that's going to inactivate them and then render them closer to the water soluble format for renal excretion. The hormones that are steroid derived are our sex hormones, estrogen, androgens, progesterone, and then cortisone and aldosterone from the adrenal glands. So here's that mechanism. So here is your steroid hormone. It's going to pass directly across the cell membrane. It's going to go into the target cell. We have a receptor in the nucleus, or we may have a receptor on certain proteins that are within there, and you may have the receptor hormone complex this way, or you actually may go into the nucleus and signal the receptor complex within the nucleus, but it's going to be a direct action on that cell. The peptide derived hormones, these are chains of amino acids. They do need a receptor on the outside of the cell, so they are not a direct action. They have to do more second messenger. What this is going to do is alert second messenger molecule inside the cell. It's going to activate those other enzymes and then influence cellular proteins, gene expression. Peptide hormones are catabolized by circulating enzymes, and then they are going to be eliminated in the feces and urine. They are free and unbound. Examples of your peptide derived hormones include antidiuretic hormone, oxytocin, growth hormone, follicular stimulating hormone, and insulin. The last one are the amino acid derived, and those are from tryptophan and tyrosine, and this would be your catecholamines, epinephrine, and norepinephrine, as well as thyroxine, which is T4, melatonin. These are also water soluble, and they also need second messenger. So everything that we talked about over here, the amino acid derived follow that as well. And then here is that second messenger situation, so non-steroid hormone. It has to bind receptor on the outside of the cell membrane, and then it's going to activate second messenger and come in here and have the effects on the cell that way. So when we're talking about ways that we test endocrinology, we kind of do opposites, and that's related to that negative feedback system. So if we need to look hyposecretion of a hormone, we actually try to stimulate the glands. If we're looking for hypersecretion, we try to suppress it. And we do not do well with random hormone levels. We really need to either catch them at their circadian or diurnal secretion when they're the highest. So timing has a lot to do with when we're looking at proper hormone levels. Testosterone needs to be drawn before 10 a.m. Cortisol needs to be before 8 a.m. So all of things really matter, and random hormone levels do not give us a lot of information if we're looking for pathophysiologic disturbances within the endocrine system. There are also endocrine disrupting chemicals, and this is kind of high yield when we talk about environmental nursing. So these enter the environment through industrial urban emissions, agricultural runoff, processing of waste. And they basically come in here and block our natural hormones receptors. So they can really cause some issues. And here's just ways that we look at endocrine disruption. A lot of infertility issues, situations where we have stimulation of stereogenic enzymes, we have increase in co-activators, decreased receptor activation, so all of those things are very problematic. And we're talking about disrupting the hormonal systems. The EDCs can actually increase or decrease the level of hormones in our body as well. And that's going to affect how they're made, broken down, stored, and then they also can change the sensitivity to our own hormones and cause issues that way. The big name things that we talk about, the dirty dozen. So these xenoestrogens, these are hormone disruptors. So they are basically mimic bad estrogen. So this is where we look at BPA, phthalates, phenol, or that parabens are another bad thing. And then pesticides, obviously used in conventional produce, also can be found in tap water. This would be your DDT, T4D, glycophosphate. A good place to use for looking at all of the dirty dozen of the endocrine disruptors is called the Environmental Working Group, and that website is ewg.org. And this is actually really good to look at suntan lotion, what you buy for your hair, skin, and it really looks at these endocrine disruptors. Okay, so let's get into endocrine structure function review. So now we're going to get into the actual glands and then the stimulus, which comes from the hypothalamus, anterior pituitary, and then release. And then the way that endocrine is set up, and the better way to understand it, is we're going to go into each area and then review structure function related to how pathophysiologic disturbances that happen with endocrine. So the main two, which are in the brain, are the hypothalamus and the pituitary. When we're talking about most of endocrine, it is the anterior pituitary. There's only two hormones that come out of the posterior. Hypothalamus releases to the pituitary, and then the pituitary releases to these endocrine glands called the thyroid, adrenal, gonads, which are testes or ovaries, male versus female, and then the pancreas, the islets of Langerhans, and that is going to be the endocrine pancreas. Other organs that have endocrine functions: brain, heart, liver, GI, and fat. So this is the HPA axis or the HPT axis we're talking about based on the gland. Hypothalamus is H, pituitary is. So let's say we have the adrenals, so then that's going to be HPA, thyroid, HPT, HPG is going to be the gonadals, but you get the gist. That's where we are. We then have a feedback loop. We will have the effector organ going to the pituitary in addition to the hypothalamus, whether positive or negative feedback control. So these are nice slides coming up here to synthesize where the hormones are coming from and then the target gland that they are working on. So we have the anterior pituitary, which again has most of our hormones coming out of. And then we have the posterior pituitary, which controls antidiuretic hormone and oxytocin only. So those are the two hormones that come out of the posterior. The rest are anterior pituitary, and they include prolactin, FSH and LH, TSH, ACTH, and GH. So let's talk about this. So we have internal and external stimuli, such as neurotransmitters. They are going to provide stimulus for the hypothalamus. The hypothalamus is then going to target whichever pituitary hormone they want to start releasing with a releasing hormone. So let's do thyroid again. So then we have thyrotropin releasing hormone. Goes through the pituitary stalk and goes into the anterior pituitary. So we're working on the thyroid line. So it's going to stimulate thyroid stimulating hormone. And that thyroid stimulating hormone is going to stimulate the thyroid gland to produce T3 and T4. And then that is going to travel within the blood system to wherever the receptors are and stimulate their response. There are some inhibitory hormones over here. So prolactin is actually turned off by dopamine. We're going to talk about that in reproductive system next. FSH and LH, they are going to work on male or female. So we have testes or ovary based on whatever the sex of the child is. And then we're going to stimulate androgen release. We're talking about the adrenal glands. We have adrenocorticotropin releasing hormone from the hypothalamus. Then we get adrenocorticotropin hormone goes to the adrenal glands, and then we get our corticosteroids. Growth hormone, this would be stimulated by growth hormone releasing. And then that's going to go to your bone and soft tissues for growth. The next slide really helps you see where we have positive and negatives. But so we have gonadotropin releasing hormone, corticotropin releasing hormone, thyrotropin releasing hormone. Those are the hypothalamic hormones. So then they travel through to the anterior pituitary. We have the anterior pituitary hormones, FSH, LH, ACTH, TSH, and then the target organs. Prolactin and growth hormone releasing are positive or negative depending on what's going on. And the best way to remember prolactin is we don't all the time need stimulation of the mammary glands. So, dopamine is in charge of inhibiting prolactin from being released. Prolactin releasing hormone would be in charge of releasing prolactin from the anterior pituitary, and then we go to the mammary glands and stimulate milk production. Growth hormone releasing is turned off by somatostatin. So growth hormone is inhibited by somatostatin. We do need it. It is growth hormone releasing. Over here are your posterior pituitary. You can see the difference. We have direct neurosecretory. We do not have hypothalamic involvement. It goes right into the posterior pituitary, and that would be under more neuronal control. We get antidiuretic hormone, which goes to the kidney. We have oxytocin, which also goes to the mammary gland in addition to other places. Okay, let's start with the hypothalamus. So this is at the base of the brain. It is connected to the pituitary gland by the infundibulum, which is also known as the pituitary stalk. The anterior pituitary through the hypophyseal portal blood vessels is connected, and then the posterior pituitary through the nerve tracts is referred to the hypothalamo-hypophyseal tract. The hypothalamus contains special neurosecretory cells that are like other neurons, however, can synthesize and secrete hypothalamic releasing hormones. And then that is going to stimulate the pituitary to secrete those hormones, such as ADH or oxytocin. So these are these special because they can actually synthesize hormones. So when we go to the pituitary gland, we have an anterior pituitary and a posterior pituitary. The anterior pituitary is what releases most of the hormones. Remember, your posterior pituitary only releases 2. So the anterior pituitary is about 75% of the total weight of the pituitary gland. It has 3 regions, which are the pars distalis, the pars tubialis, and the pars intermedia. The pars distalis is a major component of the anterior pituitary and source of the anterior pituitary hormones. So we call the posterior pituitary the neurohypophysis because it's under that neuronal control. So we look at pituitary issues, a pituitary adenoma. So this may be more than likely a benign tumor. It is the 3rd most common intracranial neoplasm in adults. When we're talking, we have twofold things that we have to do in the endocrine system. One, we have to find out if it's malignant or benign, and 2, we have to find out is it functioning versus non-functioning. So those are what the main things when we're talking about endocrine we have, because we have hormones that come out. The size matters, and that really helps us with is it cancerous or benign, and then is hormones coming out of it or non-hormone, which would be non-functioning. So even if it's non-functioning, if the size is big enough, we have problems because of the location of the pituitary gland. So what happens is you actually have your optic chiasm, and if the size of the pituitary tumor is large, then it actually will press on the optic chiasm, and we will have problems with the vision. And that's actually one of the hallmark problems that we get with pituitary issues is that mass effect. So it would be pushing on the optic chiasm, and we would get some visual disturbances. That is labeled as bitemporal hemiopsia, and that is due to compression of the optic chiasm. We have hypopituitarism that happens due to compression of the tissue, and you also may have compression of that stalk. If there's compression of this stalk, then all those hormones are going to not get where they need to be because nothing's going to stimulate. Functioning is going to depend on which hormone is affected, and you actually have to test for all the hormones. Signs and symptoms would also be dependent on the secretion of which hormones. Signs and symptoms, and this is literally covering every hormone and the major signs and symptoms that come with pituitary issues. So as you can see, a pituitary workup uh, does cover a lot of signs and symptoms. Here's an example of that mass effect that happens related to the visual disturbances related to that optic chiasm. So if you're looking for mass effect, you're going to be looking at headaches, visual disturbances related to that compression and issues with the optic chiasm, and then anything within the brain, remember, can cause seizures. Acromegaly. So this is a rare chronic disease by excessive secretion of growth hormone. Here are just a couple. Andre the Giant was one of them. And this is due to pituitary somatotrophin adenoma. So we have that acral growth. We have very coarsening of features, and they're very distinct looks to them. They will also have really big hands. Their shoe size will change. So, this is something that is normally under a predictable pattern of sleep regulated peaks of growth hormone. That is lost because we have that adenoma. And then we have unpredictable secretory patterns, and we basically have an onslaught of excessive growth hormone and insulin growth factor 1. So, this would be gigantism if it happens in children and adolescents because those epiphyseal plates have not closed. So, we have hypopituitarism. So, this is the absence or deficiency of one or more of the anterior pituitary hormones, or the complete failure of the entire pituitary, which then would incorporate the anterior and posterior. The most common is the result of a pituitary adenoma, pituitary surgery, or radiotherapy. There also can be issues with pituitary apoplexia or Sheehan syndrome, and this would be a pituitary infarction, an aneurysm. Also, sickle cell disease can cause problems with this. The pathophysiology of this is that the pituitary gland is very vascular and relies heavily on that portal vein from the hypothalamus, and it's very vulnerable to ischemia and infarction. So this results in tissue necrosis, edema, swelling of the gland, and then the expansion of the pituitary within that fixed compartment, which is called the cellulurgia, further impedes the blood supply of the pituitary. So, again, dependent on which hormones are affected, that's what's going to be your presenting signs and symptoms. If they are all affected, we call that panhypopituitarism, and then patients need to be replaced on the hormones. When we look at that posterior pituitary gland, we're looking at antidiuretic hormone or oxytocin, again synthesized in the hypothalamus by those neurosecretory cells, travel to the posterior pituitary for release. So the ADH acts on those distal tubules and collecting ducts of the kidney to promote free water retention, anti-diuresis. Oxytocin is going to mediate uterine contraction during labor and release of breast milk in the lactating mother, charge of letdown. So diabetes insipidus would be related to antidiuretic hormone, and that's when the AVP secretion fails, leading to inability to resorb that water and sodium and produce concentrated urine. So, hypothalamic or pituitary injury would be the main cause, and this could be temporary or permanent. And then there's other brain disorders such as tumors or damage to the pituitary stalk, such as head trauma or pituitary surgery, that would lead to this as well. And again, they can be temporary or permanent depending on what the cause is. We have two main types. We have central and nephrogenic, and that is related to the kidneys either responding to antidiuretic hormone or whether it is an ADH deficiency, which is in the brain. This is a nice little schematic which delineates, where is that pathophysiologic disturbance, where is the cause, whether it's central versus nephrogenic. Nephrogenic means that we have no problems with production of ADH, but the kidneys do not respond to the ADH in those tubules, And then that not responsive to vasopressin because those kidneys, whether it's exogenous or endogenous vasopressin or ADH, they are not going to respond to it. And then we have to look at, is it medications, which lithium is the big one, or is it an inherited mutation to antidiuretic hormone? But there would be no response to interventions, and then we have to treat differently. So we get excessive free water excretion, polyuria, polydipsia. We get dehydration, hypernatremia, and if there is inadequate water intake to compensate for that loss of water. So we have that loss of free water, and we have dehydration, hypernatremia, high serum osmol, low urine osmol, and specific gravity. The other thing that may happen is excessive ADH release or secretion, and then that would be syndrome of inappropriate antidiuretic hormone secretion. So this is going to be the retention of free water, and this is also related to the posterior pituitary and antidiuretic hormone or vasopressin. Both of those are interchangeable. And we get excessive renal water retention coupled with normal sodium excretion. That is going to result in hyponatremia, and then we're going to have a low serum hypoosmolality. Urine is concentrated and it has a high osmolarity. The hyponatremia and hypoosmolarity may improve by restricting water intake. This can be caused by multiple things. The most common is ectopic AVP production by tumors in small cell lung cancer, and then also cancer cells of other sites. So this is often where we get SIADH from. Other causes would include central nervous system, trauma, pulmonary infections, and medications. And then there is the pathophysiology of SIADH, increased levels of antidiuretic hormone, renal tubules permeable to water. We got water reabsorption that results in increased blood volume, increased serum hypoosmolarity, dilutional hyponatremia. Over in the urine, we're going to have decreased urine volume because we're reabsorbing more water, and we are going to have increased urine osmolarity and increased urine sodium. That's also going to result in decreased aldosterone, and we continue on that pathway for dilutional hyponatremia. When we talk about the anterior pituitary, the other oxytocin, there are really no issues with this. Moving on to the thyroid gland. So when we look at a thyroid gland, again, we have the hypothalamus, we have thyrotropin releasing hormone, thyroid releasing hormone. We go to the anterior pituitary gland, we get thyroid stimulating hormone. We go to the thyroid, we get T3, T4, we also get calcitonin. Thyroid is heavily involved in the controlling of our basal metabolic rate, growth, and maturation. All right, when we talk about structure function of the thyroid gland, it is that little butterfly gland located in the neck just below the larynx. We have 4 parathyroid glands, and they are completely separate than the thyroid gland. So they are independent of the parathyroid and thyroid. Parathyroid glands, and they are on the posterior side of the thyroid, and they're in control of calcium metabolism. So we have 2 lobes of the thyroid gland, and they lie on either side of the trachea. They're inferior to the thyroid cartilage, and they cross the anterior surface of the trachea, and they are joined by a small band of tissue, and we call this the isthmus. We have a pyramidal lobe, which is superior to the isthmus. The normal thyroid gland is not visible on inspection, but it may be palpated by asking the patient to swallow, and then it causes it to be displaced upwards, and that allows us to palpate it. If there are overt issues such as a goiter, you can see it from across the room. So the thyroid gland, we get T4, and then T4 is actually a pro-hormone, and it gets converted to T3 at the sites. So here it's heavily involved in cholesterol synthesis, reabsorption, and in fact, oxidation, as well as gluconeogenesis. It does have fatty acid mobilization, increases heart rate and hypertrophy, decreases TSH production, right? That's in negative feedback, and then increases growth hormone. It's involved in growth and metabolism. It is going to increase protein catabolism, glucose utilization, and fat oxidation. It is going to increase growth and maturation and increase bone resorption. So, also found in the parathyroid gland are parafollicle cells, which we call C cells. So, here are these parafollicular cells called the C cells, and they actually secrete the calcitonin. Calcitonin is involved with our regulation of vitamin D and calcium and bone. So this was in the thyroid gland. So we have follicular cells, which line, and then we have a colloid area in here, which is a glycoprotein. The follicular cells are what are going to synthesize the thyroid hormone. So this whole unit is what we called a thyroid follicle. So when we look at the synthesis of thyroid hormone, so here's that colloid, here's those follicular cells, and then here's the blood system. So from that anterior pituitary, we get the thyroid stimulating hormone. It goes to a thyroid stimulating hormone receptor on the thyroid gland. It initiates protein synthesis. There's a couple enzymes involved, and we get thyroglobulin. Thyroglobulin goes into the colloid. It joins with iodine, and then we have synthesis of T3 and T4, gets taken back into the follicular cell, a couple different peptidases, proteases, and we break down the thyroglobulin and we get release of T3 and T4. T3 and T4 are then released out of the circulation and go to target cells. Once in the target cell, T4 is actually converted to T3 and reverse T3, and then T3 goes into the nucleus and we get gene expression, protein synthesis involved in all of those metabolism, growth, and development. Over here we have iodide, which is an inorganic form of iodine, and then that is actively transported, pumped from the blood into the colloid by carrier proteins located in the outer membrane of the follicular cell. This active transport system is called the iodide trap, and is very efficient at accumulating trace amounts of iodine from the blood. Iodide is then oxidized and quickly attaches to tyrosine within the thyroglobulin molecule, and then that is formed in a coupling with two T3s and two T4s. Thyroid hormones are stored attached to the thyroglobulin within the colloid until they are released in recirculation. The thyroid gland produces about 90% T4, 10% T3. Once released into the circulation, T3 and T4 are primarily transported bound to one of three carrier proteins. So we have thyroxine binding globulin, albumin, or lipoproteins. Now we'll get into the disturbances of the thyroid gland. So first up is a thyroglossal duct cyst. This is a cystic dilation of thyroglossal duct remnant, and it is most common congenital neck lesion in children, and they are cysts of the epithelial remnants of the thyroglossal tract and present characteristically as a midline neck mass at the level of the thyrohyoid membrane. So they're closely associated with the hyoid bone. Although it is considered a congenital neck lesion in children, it can present in older, age 20 or older, and that's approximately 1/3, but 2/3 will present as children or adolescents. Male and females are equally affected, and then patients who have this presentation have ectopic thyroid glands. So the two main things that happen with the thyroid is we have either hyperthyroidism or hypothyroidism. Now, that does not give you etiology. So we have the condition, which is hyperthyroidism, and then you need to figure out what the etiology is. So hyperthyroidism is overactive thyroid gland, produces increased amounts of circulating hormones T3 and T4, and that is going to increase metabolic processes, and that's due to increased synthesis of sodium potassium adipase. There is also increased sympathetic system, and that is due to increased expression of beta adrenergic receptors. So it actually upregulates beta adrenergic when we have increased T3 and T4. Three main causes of hyperthyroidism are Graves' disease, multinodular goiter, and thyroiditis. Basically, metabolism goes into overdrive. Here are these three causes. Okay, so we have number one, which is Graves' disease. This is autoimmune and usually the most likely cause of it. Number two is a toxic adenoma or multinodular goiter. Number three is acute thyroiditis. So you can see here then the pathology. So Graves' disease is autoimmune, and we have increased TSH receptor issues because we have antibodies against those TSH receptors. They sit on the receptor and actually activate T3 and T4 production within the gland. For toxic adenoma and multinodular goiter, The thyroid production is independent of the TSH, and basically we have a haywire little nodule, and it's producing extra T3, T4. And then acute thyroiditis is usually secondary to a viral infection. There are other causes. And then what happens is there's damage to the thyroid follicular cells, and it results in hypersecretion, and then actually goes into hyposecretion, and then it goes back to euthyroid secretion. We'll talk about that a little further. So you can see here following of, so you have your mechanism, and then you have your signs and symptoms. So again, this is a very good way. I love these little guides to tell you exactly why you're getting your presentation. So Graves' disease is an autoantibody stimulated receptor. It is classified as a type 2 hypersensitivity, and this leads to increased synthesis and release of T3 and T4. You can have a diffuse goiter with this, and that is overactive stimulation of that gland, which leads to hypertrophy and hyperplasia. Characteristic signs and symptoms include exothalamus and pretibial myxedema. I have a picture coming up. Thyroid storm is a potential fatal complication of untreated Graves, and it can be fatal. So what happens in Graves' disease is we have that pituitary release of the thyroid stimulating hormone, goes ligand onto the TSH receptor, stimulates hormone synthesis, regulated by negative feedback control. What happens in Graves' disease is we have an antibody to the receptor. It stimulates the hormone and produces unregulated production of thyroid hormones, and there is no turning off of this, and that's where we get it. So what happens with this is then the TSH is going to be super low because we have so much hormone in the system that the TSH is going to try and shut it down. So these are going to be TSH levels less than 0.5, 0.4. All depends what your laboratory labels it as. Normal TSH ranges, if you just kind of memorize 0.5 to 4.5, you're pretty good. But again, it may vary based on whatever lab result you use. So then what happens with T3 and T4? They are going to be elevated. We really look at T3. Remember that that's the more active hormone. So your T3, if it's dramatically more higher, then you know that these patients will likely be presenting with signs and symptoms very consistent and high risk for the hyperthyroidism and cardiac issues. So this is exothalamus, so that eye bulging, and they do look like they're going to pop out of the skin, out of the eye sockets. And then this is the pretibial myxedema. So when you press in on it, it kind of feels like you're pressing in on dough. So when you go back to signs and symptoms consistent with hyperthyroidism, the body goes into overdrive. So what are you going to get? You are going to get tachycardia, palpitations. You can have a bruit over the thyroid gland, and you're going to have decreased exercise tolerance just because of that cardiac issues, cardiac output issues. You will also have diarrhea and increased bowel movements. We call this hyperdefecation. You will get nervousness, hyperkinesia, hyperreflexia, tremors, poor attention. You will have increased weight loss, and usually this is one of the hallmark signs that we get. You're going to be heat intolerant, and you're going to have increased appetite, but you will be losing weight. All of that is related to increased metabolic drive, increased sympathetic stimulation, thermogenesis, cardiac output. And then here are your ptosis and diplopia. We also have lid retraction, and that basically means that the lids are pulled back. And you can see a conjunctivitis as well. Here is that pretibial myxedema. That is increased hyaluronic acid in the dermis and subcutaneous area, and that presents with that doughy situation. The way that we are going to test for this is we're going to be looking for antibodies. So if you have TG antibodies, exothalamus, and pretibial myxedema, you have Graves' disease. So the other thing that happens with the thyroid gland is that we get a thyroiditis. So this is an inflammation of the thyroid gland, and what happens is it can be multiple causes. So we have a postpartum thyroiditis, we have a bacterial, we have a viral, we have drugs, radiation induced. Basically, what happens is we get infiltration of immune cells into the thyroid gland. It's immune mediated damage. There are certain things that are more consistent with one thyroiditis versus the other. So what happens then is we have that infectious etiology or postpartum causes the inflammation. Then what happens is we get released T4, T3 over a 2 to 6 week period, and that creates this hyperthyroid phase. So you can see here all of the things. We get those general symptoms of hyperthyroidism, and you can refer back to the hyperthyroidism slide. We would then have low TSH secretion. Depending on where you would pull the TSH level, you actually may get into euthyroid, hypothyroid, or hyperthyroid states. So then after we have that hyperthyroid state, we get decreased secretion of T4 and T3 from the gland because it's now damaged, and that will precipitate a hypothyroid phase. After that happens, then we should return to normal, which we term euthyroid, but patients can remain hypothyroid. You would be getting different TSH levels through all of this. And that's why, depending on where you would pull a TSH in this process, you may have conflicting data. All right. So 1 week you pull it and it's hyperthyroid. You tell them to come back in 4 to 6 weeks. Now they're hypothyroid. That's a clear indication that this is a thyroiditis. We have a couple different types. Your painless thyroiditis does not have pain of that when you palpate the thyroid gland. And this is a sporadic type, postpartum, biologic agents, and lithium therapy. Subacute, this is usually related to a viral etiology, and then it is characterized by the triphasic transient thyrotoxicosis, and this would have moderate to severe pain in the thyroid gland and tenderness. We have a couple different other types, so these are a lot more rare. So we have decurvin thyroiditis. This is usually self-limited, rarely progresses to hypothyroidism. Tender thyroid with transient hyperthyroidism, again, follows a viral infection. Rydell fibrosing thyroiditis, this is a chronic inflammation with extensive fibrosis of the gland, and that would be evidenced on imaging when you got it. Hard as wood, as is what we kind of say with this one, non-tender. Moving on to the multinodular goiter. So this is an enlarged goiter or palpated nodules on exam. So what happens is we have hypertrophy and hyperplasia. It is iron deficiency and genetic susceptibility. And in the industrialized places, it is usually due to a genetic susceptibility. In unindustrialized, it's due to a relative iodine deficiency. A lot of times they do not have iodine in their diet, and they come in with these iodine deficiency states, which they'll have a goiter. So here's the hypertrophy mechanism. So efficient adaptation of iodine metabolism. This is going to increase clearance, uptake, genetic expression, results in a diffuse goiter. In hyperplasia, so we have iodine metabolism is inadequate, altered hormone synthesis, proliferation, mutagenesis, somatic mutations, goiter, and then we have mutational expansion cell clones. We term these hot or cold nodules by if they are risk cancer versus more benign. And you can walk around with a multinodular goiter and it doesn't cause any problems. And that's where we say toxic versus non-toxic. So toxic is that there's going to be thyroid hormone coming out of it. Non-toxic means no excess hormone. And this is what it would look like from when you would be looking at it on a patient. So the opposite end is hypothyroidism. So this is underactive stimulation and release of hormones from the thyroid gland, be a decreased metabolic rate and decreased sympathetic nervous system stimulation. Like with hyperthyroidism, we have multiple causes of hypothyroidism. Usually it is an autoimmune process as well, and that is termed Hashimoto's thyroiditis. Other is iodine deficiency, again, more common in non-industrialized countries. And then we do have certain medications. The other way that we get it is acquired hypothyroidism, and this is due to surgery or radioactive ablation secondary to Graves' disease. There is a severe hypothyroidism state called myxedema coma, and this can also be fatal. Hashimoto's thyroiditis is autoimmune destruction of the thyroid gland, where we have iodine placed into the diet. We look at most likely autoimmune destruction. You can test for the antibodies. So what results is follicular damage. You may have hyperthyroidism at first, and then it progresses to hypothyroidism. So we have anti-thyroglobulin and anti-thyroid peroxidase antibodies are often present, and this is what we test for to make sure that it is autoimmune. Again, the pathogenesis, so Hashimoto's versus pituitary, we call this central hypothyroidism, so then there would be an issue with TSH. Hashimoto's is progressive autoimmune destruction of a thyroid gland. Here is transient, iatrogenic, congenital, iodine. Ultimately, it all results in a hypothyroid state. So here you can see the mechanisms. We have decreased secretion of T4 and T3 from the thyroid gland, and we would have a decreased inotropic effect on the heart, so that would be bradycardia. Contractility and rate of contraction is also decreased related to the cardiac myocytes, results in decreased heart rate. What you're going to have here is elevated TSH levels, except for central hypothyroidism, then we would have decreased. We're talking about hypothyroidism, your TSH is going to be above 5. We call subclinical 5 to 10, and then greater than 10, you treat. And then your T3 and T4 are going to be low because there's no hormone coming out of the thyroid gland. So then we also get slowing down of the entire metabolic. We would have issues with menses for females, infertility, and we have more slowing down neurologic symptoms, depression, somnolence. There's also delayed function, and we actually get some motor slowing. Muscle cramps, joint pain, poor muscle tone, delayed relaxation. So then you can see decreased effects over here. We have a narrowed pus pressure. Here is that myxedema coma, weight gain, cold intolerance, cold hands, fatigue, dry skin, thickened skin, hoarse speech, and then our hyperlipidemia, triglycerides, and LDL would all be elevated because we're going to impact that lipid metabolism. So here's a look at the pathophysiology. So we have that thyroid epithelium. So we have those follicular cells. We have a CD8 cytotoxic T cell, and it basically induces T cell mediated cytotoxicity. You can see here the CD4 T helper 1 cell. We get activated macrophages. We end up with thyrocyte injury. Here we have the plasma cell, the antithyroid antibodies. They are going to work on the natural killer cells, and we get antibody-dependent cell-mediated cytotoxicity. So here's a nice slide for hypothyroidism and hyperthyroidism, and you can just see the variation and the difference. If we have issues with hypothyroidism in neonates and infants, and this would be related to uncontrolled hypothyroidism, most likely in the mom while she is pregnant, what is amazing that is if we correct this, you can see once we get the thyroid hormone appropriately maintained, we actually get back to normal. So you can have mental retardation, short stature, skeletal abnormalities, coarse facial features. We get that enlarged tongue and umbilical hernia. And basically the patho is we need thyroid hormone for normal brain and skeletal development. This is caused by maternal hypothyroidism in early pregnancy, iodine deficiency, and then a dyshormonogenic goiter is another potential cause. Thyroid neoplasia, so this usually presents as a single thyroid nodule. Benign is greater than malignant, and this would be an increased uptake is what we term a hot nodule. That is seen in Graves and nodular goiter. If it has a decreased uptake, cold nodule, we see that in an adenoma or carcinoma, and that's where we get biopsy. Way that we biopsy it is called a fine needle aspiration. We have 4 types. We have follicular, medullary, papillary, or anaplastic. So take a look at these thyroid neoplasms, papillary versus follicular, and papillary is the most common, and it usually has a pretty good prognosis. All of the thyroid neoplasms would result in removal of the thyroid gland, and then we would have to suppress thyroid growth, and that is by a lower TSH for life. Follicular carcinoma, so this is the follicles, and that is then surrounded by a fibrous capsule with invasion through the capsule. And this usually has hematogenesis metastasis, and you would also have surgery related to this. Medullary carcinoma, so this is the rarer one, and that's that parafollicular C cells. And then basically what happens is we get increased calcitonin, and we would have low calcium as one of the signs and symptoms of this. This is also part of MEN2A and 2B, which is multiple endocrine neoplasia. These are syndromes that have multiple types of cancer in multiple endocrine organs. Anaplastic carcinoma, this is an undifferentiated tumor of the thyroid, usually seen in the elderly. Unfortunately, it has a pretty poor prognosis. Parathyroid gland, so this is those 4 small glands that are on the posterior area of the thyroid gland. They are the chief cells in regulating calcium metabolism via the PTH hormone, which is parathyroid hormone. Basically, it is a feedback system of calcium, and then that is going to release PTH secretion for mobilization. Here is the physiology of normal calcium phosphate PTH. So we have decreased calcium concentration. We then get an increased parathyroid hormone secretion from the parathyroid glands. This is going to increase parathyroid hormone concentration. So in the kidneys, it's going to decrease renal tubular reabsorption of phosphate. It's going to increase excretion of phosphate, and it's going to decrease the plasma phosphate concentration. In the bone, it's going to increase resorption and increase calcium release into the plasma. Ultimately, we're trying to get blood plasma back up. In the kidneys, it's going to increase renal tubular reabsorption of calcium, bringing it back into the blood, and it's going to decrease urinary excretion of calcium. So in the kidneys, vitamin D related, it's going to increase formation of D3 by the kidneys. That's going to increase the concentration of D3, and that is going to increase calcium absorption from the intestine, ultimately resulting in plasma calcium concentration to normal. So primary hyperthyroidism is something is wrong with the gland. Always primary means the gland is the problem. So we have excess parathyroid hormone due to usually destruction of one of the parathyroid glands. It's usually due to a parathyroid adenoma. There is also sporadic hyperplasia and carcinoma, which is much less common. It does include usually 1 out of the 4 and is a benign neoplasm. We usually go in and remove it. So what happens is we get this asymptomatic hypercalcemia. So a lot of times you're only going to find this on lab work, and we would have an elevated calcium. And then you would work up for primary hyperparathyroidism by obviously drawing a PTH and see where it's at with calcium. If it's inappropriately elevated with a normal calcium, then we would get concerned that there is an adenoma that is functioning and giving us excess PTH. So when we have hypercalcemia, there's a nice little mnemonic for you. Either one of these works: moans, groans, stones, and bones, or painful bones, kidney stones, abdominal groans, and psychiatric moans. And these are just those classic signs of hypercalcemia and where it affects. You can have a secondary hyperparathyroidism, and this is related to renal failure is the issue, and then that's going to have excess production of PTH due to that issue with the decreased phosphorus. So your renal insufficiency leads to decreased phosphorus, binds free calcium, calcium levels fall, stimulate parathyroid, leads to bone reabsorption, and then renal osteodystrophy. When we talk about hypoparathyroidism, so this would be low PTH. This is usually due to autoimmune damage to the parathyroid gland, surgical excision, or DiGeorge syndrome. You would present with low calcium symptoms, which is numbness and tingling. When it gets low, you have circumoral numbness and tingling. Tetany would be positive trousseau and Chevstick signs. You can have a pseudo-hypoparathyroidism, and this is hypocalcium with increased PTH. This is an autodominant issue, and it's associated with short stature and short fourth and fifth digits. Moving on to the pancreas. So we're going to be talking about diabetes, type 1 and type 2, and taking a look at the pathophysiology of these. This is obviously something that you're going to be dealing with a lot in primary care.
Pancreas has both exocrine and endocrine function. The main functioning units of the endocrine pancreas are the islets of Langerhans, and they include 4 types of cells in the islets of Langerhans, and they consist of beta, alpha, delta, and F or PP cells. The F or PP cells, depending on what source you look at, are related to the GI, so we're not going to focus there. The other ones are insulin and glucagon, gastrin, and somatostatin. So the beta cells are in the center of the islets, and then the glucagon, the alpha cells, are in the outside. And these are basically the regulation of your sugar. And one is going to increase insulin production. The other is glucagon, which is counter-regulatory to insulin and blood sugar. So insulin is an anabolic hormone that upregulates insulin-dependent glucose transporters on skeletal muscle and adipose tissue. Amylin is a polypeptide amino acid that is secreted with insulin by the pancreatic beta cells, and that's also in response to nutrient stimulus. So then the glucagon opposes insulin in order to increase blood glucose in times of fasting via glycogenolysis and lipolysis. Then we have gastrin and somatostatin, which comes from the delta cells. And then that's going to be involved with regulation of the blood sugar, in addition to now we're getting more into that exocrine function as well. And remember that your pancreas lies behind the stomach between the spleen and the duodenum, and the main functioning unit is those islets of Langerhans. So when we talk about insulin-mediated glucose uptake, the reason that we need it is that it's very important, especially when we're talking about skeletal muscle and the ability of the muscle to receive nutrients, which again, all cells need sugar, glucose, to perform glycolysis. So this is where glucose is very important. So here is a slide of overall carbohydrate metabolism. So you can see we have carbohydrate intake from the gut system. It crosses the microvilli, gets into the blood system. So we have glucose circulating in the blood. Non-insulin mediated glucose uptake is what NIMGU stands for. And if it's insulin mediated, you will just have a positive insulin. What happens at the target cell is insulin binds with an enzyme-linked plasma membrane receptor that contains tyrosine kinase on the cytosolic surface. So insulin receptor binding sends a cascade of signals to active glucose transporters. So that's what these GLUTs are, glucose transporters, and we have multiples, for entry of glucose into the cell. The primary GLUT is called GLUT4. It is stored in the cellular vesicles until activated by the insulin receptor, and then is translocated to the cell surface, where it facilitates the diffusion of glucose into the cell. Translocation of GLUT4 on the cell surface is associated with a 10 to 21-fold increase of glucose diffusion into the cell. And that particularly happens with the liver, adipose cells, skeletal, and cardiac muscle. The only one that's not listed here is cardiac muscle, but it would, skeletal muscle and cardiac muscle. Insulin sensitivity, which is denoting the biologic responsiveness to insulin, is affected by age, weight, body fat, and how much abdominal fat is present, as well as physical activity. That is where we get the hallmark of resistance. So sensitivity means that everything is working well, and the GLUT4 is regulated once the insulin gets to the area. So when we have insulin resistance, this is a subnormal biologic response to normal insulin concentrations. So then we have adipocytes. They release a number of hormones that are altered in obesity and have very important adverse effects on insulin sensitivity. And this is where we get the most effective weight loss and improvement of type 2 diabetes, because we're actually working on the adipose tissue. So you can see here for the central nervous system, it is non-insulin mediated glucose uptake. Remember that glucose is the main source of fuel for your skeletal, brain, adipose tissue. So when we look at the regulation, so we're obviously getting homeostasis, and then that would change based on, do we have a stimulus such as rising blood sugars after eating, or do we have removal of that stimulus such as a fasting state or skipping meals? Here we have high blood sugars, beta cells release insulin. Insulin goes to the body cells to take up more glucose. It goes to the liver and basically says, we're going to store this, take up this extra sugar because we don't need it for energy. Glucose levels go back down, and the insulin release diminishes. Vice versa, if we have low blood glucose levels, then the alpha cells are going to release glucagon. Glucagon goes to the liver, breaks down glycogen, releases it into the system, and then that gives us increased blood glucose levels going back up to normal, and the response for glucagon then diminishes for that feedback system, and we get homeostasis again. Type 1 diabetes is an insulin deficiency that leads to a metabolic disorder characterized by hyperglycemia. This is the more rare type of diabetes, only accounts for 10 to 15% of diabetes. What happens here is we have autoimmune destruction of the islet cells caused by T lymphocytes. We actually order antibodies to test for type 1, have about a 95-96% specificity. If they're present, you have type 1 diabetes. And what happens is shut down the beta cells and we get uncontrolled glucagon, and that leads to gluconeogenesis, glycogenolysis, and lipolysis, which leads to that hyperglycemic state. We have no insulin, so there's no way to combat it and get it into the cells for tissue utilization. It does manifest usually in childhood. However, you can get type 1 diabetes in adulthood, and it all depends on this autoimmune destruction and what we still do not know causes autoimmune start to disease processes. If not treated correctly, it can lead to diabetic ketoacidosis. And also if missed insulin or stress and infection happen, that can also lead to diabetic ketoacidosis. So the pathophysiology of type 1 is that there are antibodies to at least one of these three, and glutamate acid decarbolase, which we call GAD. You can have anti-insulin antibodies. You can have tyrosine phosphate-like molecules, which we call IA2. You also can have a zinc transporter. So there's a couple different types. These are the main ones that we test for when we're looking for type 1 diabetes. So here are what we think are these environmental triggers, such as the cow milk. However, we do know that we have those viruses that come in, drugs, toxins, stresses. And then genetic susceptibility, again, on those HLA mutations, ultimately ends up in beta cell dysfunction. And we have no insulin, we have unregulated glucagon, and we get type 1 diabetes. So the bad complication of type 1 diabetes is diabetic ketoacidosis. Actually, is a lot of times how they will present because they have that mismatch. So for some reason, we have that autoimmune process. It turns off the pancreatic beta cells. We have unopposed glucagon, and then we have increased hyperglycemia and no insulin. What we need to do is get insulin on board. Unfortunately, they don't have the diagnosis yet, so they present with these problems of a metabolic acidosis that can be quite severe. Once they're diagnosed and are on insulin, then what we have is a mismatch of normal insulin intake to what the patient needs in stress or infectious as that precursor. Ultimately, it ends up with decreased utilization of glucose, increased lipolysis, increased proteolysis, decreased protein synthesis, and increased glycogenolysis. We get a lot more free fatty acids to the liver. We get more gluconeogenesis. We change over from glucose metabolism to keto fat metabolism, and then that results into a ketoacidosis and a lactic acidosis, and we have hyperglycemia, acidemia, and ketonemia. You will have profound dehydration and hypovolemia because where glucose goes, water follows. It's an osmotic diuretic. So when you are urinating out all the sugar, it is going to pull the water out as well. You will have a pseudo hyponatremia. It can be severe, but you do need to correct for how bad the hyperglycemia is. And then you have that polyuria, which is classically related to that osmotic diuresis. Moving on to type 2 diabetes. So this is insulin resistance, leading to a metabolic disorder characterized by hyperglycemia. So no longer are we talking about complete issue with the pancreas. Now we're looking at we have sufficient insulin into the bloodstream. However, when it gets to the skeletal muscle, those glucose 4 receptors are not sensitive to the insulin anymore, and it's actually resistant to the glucose insulin uptake. So it shuts it down. We often characterize this as a lock and key situation. Insulin is how we're going to get the blood glucose out of the blood into the cells. So this is the most common cause, and it is getting worse. We do have a diabetes epidemic in addition to an obesity epidemic, and we need to take a lot of look at that. So classically presents middle age, obesity, We are seeing it now in juveniles if they are obese or overweight. And then there is also a strong genetic disposition for this as well. And actually, this gives you more of a risk. If there's type 2 diabetes in the family, you have a higher risk of obtaining type 2 diabetes, especially if your environmental triggers are present. So the pathophysiology of type 2 is we have that genetic predisposition, there's insulin resistance, and there's insulin deficiency. At diagnosis, the pancreatic function is about 50% that we're aware of. They do think that it may be actually higher. So then we have that resistance in the muscle liver cells, beta cell failure. These are the key pathophysiologic defects. However, we are at the gregarious 11 with 11 different disturbances that we think are going on for diabetes. That's just a theory, but that's where we're at. We went from 8, the ominous octet, up to 11 disturbances. So insulin resistance is aggravated by getting older, physical inactivity, and overweight or obesity. These are all independent factors alone without that genetic predisposition. So then we have complex derangements in cellular receptors, intracellular glucose kinase function issues, and then other intracellular metabolic processes are impacted. So when we talk about the gregarious 11, so you can see here we have that pancreatic beta cell issues, then we go into alpha cell defect, which increases glucagon. We also have an incretin effect, and this is where we're working with certain enzymes in the GI system that ultimately go over to the pancreas and stimulate more insulin release, and then they go over to the liver and give less glucagon-induced glycogenolysis and gluconeogenesis. We also have colonic biome issues, immune dysregulation, stomach intestine issues related to glucose absorption, brain issues, increased appetite, issues with sympathetic tone, increased insulin resistance. The insulin resistance hallmark in that liver, which gives us increased glucose production, muscle, decreased peripheral glucose uptake, and adipose, increased lipolysis, ultimately leading to hyperglycemia. Also now we have identified kidney issues, and that is related to the upregulation of SGLT2, and this has been a new target for medications. Down here is ways that we are targeting treatments now related to all of these 11 pathways involved in diabetes. So when you look at the pathophysiology of type 2, then this just gives you that mechanism ultimately leading in hyperglycemia. When we're talking about type 2 diabetes, we have methods for screening, and those are related to these risk factors listed here. So presentation for type 2 diabetes is going to be the same. However, you're going to have skin infections, urinary infections, and acanthus nigricans. Acanthus nigricans is directly related to insulin resistance. And then the classic triad, polyuria, polydipsia, polyphagia, are present in type 1 and type 2. Prediabetes is a syndrome where we have issues with fasting glucose levels as well as postprandial. Postprandial means after the meal. And then we would have problems with insulin resistance and that showing up. Prediabetes is an A1C of 5.7 to 6.4, or you can have a fasting glucose level 100 to 125. And then if you do test it, we would have a post-load glucose of 140 to 199. Hypoglycemia is another issue. This can present with diabetes or as a problem in itself. So one of the first things that you look at is there a diagnosis of diabetes? And then if you would have that, we're looking at, are there types of medications that would induce hypoglycemia, such as an insulin secretagogue or insulin therapy? The primary causes of hypoglycemia not related to diabetes include an insulinoma, which would be the rare zebra. We also have issues with reactive hypoglycemia secondary to gastric surgeries. There are some other rare endocrine issues, but really your decision tree is diabetes or not, and then we would have to work up and actually induce hypoglycemia related to these more rare causes. There is the pathophysiology of low plasma glucose and what happens on the cellular level with the alpha cell secreting glucagon, goes to the liver, glycogenolysis, glyconeogenesis, If there's prolonged hypoglycemia, then we would go over to fat metabolism, which would be ketogenesis. When we look at diabetic complications, we're looking at microvascular and macrovascular complications. This is directly related to the impact on the vasculature from diabetes alone. So once patients are diagnosed with diabetes, they have a 2 to 4-fold increase in cardiovascular disease, stroke, peripheral vascular disease is another manifestation. Microvascular complications would be the small vessels in the eyes, the feet, and the kidneys. Ways that we do that is diabetic control, and that's that A1C less than 7%. Also, you need to target BP and cholesterol to slow progressive disease and minimize these complications. So diabetic retinopathy is retinal capillary leakage, gives rise to intraretinal hemorrhages. We have cholesterol exudate deposition, retinal edema, and then the macula of the retina becomes involved, leading to reduced central vision. It leads to microaneurysms, cotton wool spots, microvascular abnormalities, and this is where we get blindness related to diabetes. Nephropathy, so this is metabolic alterations such as hyperglycemia, hyperlipidemia. We talked about diabetic nephropathy and renal. We get also hemodynamic alterations such as systemic and glomerular hypertension. And then these lead to inflammation, endothelial dysfunction, oxidative stress, indicated by proteinuria, means that we have diabetic nephropathy. Neuropathy, so this is both enzymatic and non-enzymatic pathways of metabolism of the glucose, impairs mitochondrial function, neurotrophic support, mediates injuries of the neurons and Schwann cells because we're in the periphery, culminating in a progressive damage and loss of peripheral nerve fibers, impairs sensory function. Macrovascular complications, so we are trying to avoid heart attack and stroke in our patients, and this would be related to accelerated atherosclerosis. Metabolic syndrome is also something to be aware of. So this is that trifecta. So we have insulin resistance, we have abdominal obesity, reduced good cholesterol, elevated triglycerides, elevated LDL, hypertension. So a lot of my patients, hyperlipidemia or dyslipidemia, hypertension, and diabetes. And this is that metabolic syndrome. The rare pancreatic endocrine neoplasms, so we can have tumor of the islet cells, we can have insulinomas, gastrinomas, somatostatinomas, and VPIomas. These are all zebras, but just be aware that these would be in your pancreatic endocrine neoplasms. Moving on to the adrenal glands, those are those pyramid-shaped glands that are present on the upper pole of each kidney. They are located behind the peritoneum. And each gland is surrounded by a capsule that is fatty, and it is well supplied with blood from the phrenic and renal arteries and the aorta. Each adrenal gland consists of 2 separate portions. The outer portion is the outer cortex, and then the inner portion is the inner medulla. The 2 portions actually have different embryonic origins, different structures, and different hormonal functions. They act like 2 separate, but they are interrelated. So the adrenal cortex has 3 layers. We have the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona glomerulosa is the outer layer, and that accounts for about 15% and is primarily where we get aldosterone. The fasciculata is where we get our glucocorticoids, mainly cortisol. That is going to be that middle layer. The reticularis is down here, and that is going to be our weak androgens. Remember that our steroids are derived from cholesterol, and then we get a sequential enzymatic modification produces those mineralocorticoids, glucocorticoids, and androgens. When we look at the adrenal medulla, this is where we get epinephrine and norepinephrine release. When we're talking about the HPA axis, so the hypothalamus is going to go give us cortico-releasing hormone. Then we have adrenocorticotropin hormone coming from the pituitary gland, and from the adrenal gland we get cortisol. If we have dysregulation, we have to figure out what it is. So we have increased cortisol or we can have decreased cortisol. Those are the 2 main dysfunctions related to the adrenal gland. Cholesterol synthesis in the fasciculata. Here are the pathways. Here's the glomerulosis and the reticularis. So in the fasciculata, we get our cortisol and our corticosterone. You can see here that we have 17-OH pregnenolone, and then it's processed with a couple enzymes, and we get cortisol. When we're talking about aldosterone from the glomerulosa, we get pregnenolone, progesterone, and then 11-deoxycorticosterone gives us the aldosterone. Zona reticularis, again, pregnenolone, 17-OH pregnenolone again, and then we get dehydroepiandrosterone, and then we get our weak androgens that come from the adrenal glands. So glucocorticoids are very important. We need them for life. They are heavily involved in metabolic, neurologic, anti-inflammatory, immunosuppressive conditions. They are released under stress. They act on nuclear, genomic, and non-genomic pathways within the cell. The term glucocorticoid refers to the steroid hormones that have direct effect on carbohydrate metabolism. These hormones increase blood sugar by concentration of and promoting gluconeogenesis in the liver, conserving glucose by decreasing uptake of glucose into the muscle cells, adipose cells, and lymphocytic cells, and they antagonize insulin. This results in increased glucose for the brain during stress. In extrahepatic tissues, the glucocorticoids stimulate protein metabolism and inhibit amino acid uptake and protein synthesis as well. The ultimate effect on the body is protein catabolism and muscle wasting. They act on several sites to suppress immune and inflammatory reactions. Remember, at that arachidonic acid, they actually suppress at the top of the arachidonic acid profile. They inhibit innate immunity through several pathways, including inhibition of antigen presentation by dendritic cells. They decrease activity of pattern recognition on the surface of the macrophages. They also decrease immune and inflammatory responses by decreasing natural killer cell activity. Other effects are they inhibit bone formation, they inhibit ADH secretion, and they stimulate gastric acid secretion. So the most potent glucocorticoid is cortisol, and this is the main secretory product of the adrenal cortex and is needed to maintain life. It regulates body during both positive and negative stress, and it has a biologic half-life of about 90 minutes, and then the liver is primarily responsible for its deactivation. Cortical secretion is regulated by hypothalamus and the anterior pituitary gland. The other hormone is a mineral corticoid. This is aldosterone, and this affects ion transport by epithelial cells, causing sodium retention and potassium and hydrogen loss. It is one of the most potent, naturally occurring mineral corticoids and acts to conserve sodium by increasing sodium pump at the epithelial cells in the nephron. So what happens here is when sodium potassium levels are within normal limits, approximately 50 to 250 milligrams of aldosterone is secreted daily. Of that, 50 to 75 is bound to plasma proteins. The proportion of unbound aldosterone contributes to rapid metabolic turnover in the liver, its low plasma concentration, and its very short half-life. Aldosterone is degraded by the liver and is excreted by the kidneys. So main job is maintains extracellular volume and blood pressure by acting on that distal nephron and increases sodium reabsorption and potassium and hydrogen excretion. When we talk about the androgens, so we have estrogen and androgens, we have that cholesterol. We basically get estrone, estradiol, estriol, as well as testosterone. And then these are converted to stronger androgens in the peripheral tissues. And that is accounting for some of the androgenic effects that are initiated by the adrenal cortex. So the adrenal medulla gives us our epinephrine and norepinephrine, and that is sympathetic division of the autonomic nervous system. And this gives us our chromaffin cells, which are pheochromocytes. And this is where we store and secrete the catecholamines, epinephrine and norepinephrine. These come from phenylalanine, and circulating epinephrine is about 30%. So the adrenal medulla functions as a sympathetic ganglion without postganglionic processes. Sympathetic cholinergic preganglion fibers terminate at those chromaffin cells, and then they secrete those catecholamines. So then once these catecholamines are released into the circulation, They have only seconds to minute of action profile, and they exert rapid biologic effects, and they're working on those adrenergic receptors, alpha 1 and 2, beta 1, 2, and 3. And then they are rapidly removed by the plasma by neurons for storage into cytoplasmic granules, and then they will be metabolically inactivated and excreted in the urine. This is related to that fight or flight that we were talking about with the neurosystem. All right, the main disturbances related to the adrenal glands are too much cortisol or too little cortisol. So one of the main issues is Cushing's disease, and we can have Cushing syndrome and Cushing disease. When we're talking about Cushing disease, it is a pituitary-dependent hypercortisolism. So we have increased ACTH secreting pituitary microadenoma, and that is going to increase cortisol from the adrenal glands. There is loss of that diurnal and circadian rhythms to the ACTH secretion, cortisol release, and it lacks the inability to change in response to stressors. So signs and symptoms are related to hypercortisolism, and that would be hyperpigmentation in a specific pattern, truncal obesity, which we call apple or central, moon facies, buffalo hump, muscle weakness. Here is the classic presentation of Cushing's, and you have the fat pads, the facial plethora, which is red cheeks, moon face, very easy bruisability and ecchymosis, elevated high blood pressure, elevated blood sugars, pendulous abdomen, and red striation or violaceous striation, thin arms and legs, and all central obesity. So then we have the opposite, which would be Addison's disease, and that is adrenal insufficiency secondary to lack of stimulation from the ACTH or lack of adrenals to respond to the ACTH, and ultimately leads in adrenal hypocortical function, and that gives us low cortisol, low aldosterone. So that's going to lead to weakness, GI disturbances, hypoglycemia. You still will get some hyperpigmentation, but then you will have hypotension, increased potassium, and decreased sodium. And that's secondary to cortisol and aldosterone. We can have a secondary hypocortisolism, and that is after exogenous glucocorticoids or effective treatment for endogenous hypercortisolism. The clinical manifestations will be the same regardless of the cause. Go ahead and check out that clinical findings pathway here and why we get the signs and symptoms that we do. Hyperaldo, so this is increased aldosterone. It's going to lead to hypertension, hypokalemia, and metabolic alkalosis. Aldosterone is involved in increasing absorption of water and secretion of potassium and hydrogen ions in that distal tubule and collecting duct. Etiology is not known, but we think that there is genetic components, bilateral adrenal hyperplasia, or an adrenal incidentalloma. Adrenal incidentalloma is a usually benign adenoma that is found incidentally, meaning that the scan is done for some other reason and we find it. Regardless of whatever cause it is, we have autonomous excessive aldosterone, and there's no regulation by its normal regulator, which is the renin-aldosterone angiotensin system, and that leads to excessive sodium, leads to hypertension and hypokalemia. There is your pathway for your aldosteronism. The rare zebra is a pheochromocytoma, so this is a very rare adrenal tumor. It does produce signs of the norepinephrine and epinephrine, and that's because it's in that adrenal medulla. Remember that those are those catecholamines. So you get this catecholamine cascade, and you get these spells that are diaphoresis, tachycardia, palpitations, also can have headaches and flushing. And these kind of come and go. They're not necessarily consistent, but these are extremely problematic related to that catecholamine induction.